All right, so welcome to Project Echo. The title of this Echo is Addressing Opioid Addiction Through Community-Based Collaborative Relationships. My name is Cedric Weatherspoon. I'm the co-director of the Project Echo along with Crew Fam, who's also co-director. He's down there waving with his mask on. I just want to start just an intro of myself. I'm the president of Empower Therapeutic Support Services. I have over 20 years of experience with working with individuals and families in the community. I've been working in mental health since I was 19, and I've been a part of a mental working with being around people with mental health issues since I was a child. My mom suffered from mental health conditions. She was bipolar. And so that was interesting perspective as a child. And I'm passionate about addressing disparities in healthcare. And when I say healthcare meaning mental health and physical health. So I look at it too as, just a combination of the two integrated together. So I just want to just kind of give a background of this, my experience as a leader in the community. One of the leadership models that I operate from is the systemic leadership. And so if you were at the first Project Echo, I talked a lot about being systemic leaders. So for you who weren't at the Project Echo, the first Project Echo, here's kind of a blurb. A systemic leader understands that everyone has the opportunity to become a leader around a given situation. Systemic leaders understand the power in their ability to influence the collective. So some of the traits of systemic leaders are being knowledgeable. So being knowledgeable does not mean book knowledge. You can be knowledgeable about your community. You can be knowledgeable about your family. All knowledge is welcome in this systemic leadership approach. We're flexible. So earlier we talked about like political climates. Those are things that we kind of have control over. And it can be a struggle sometimes. Working across the aisle, but being flexible is being welcoming all opinions and engaging in impactful conversations. Also, we're problem solvers, and given the environment, we're coming off COVID. We're also dealing with a mass amount of residual symptoms related to COVID and mental health issues in our schools, in our communities, in our families. The best approach that systemic leadership look at this is we look at it as being how to solve these problems as a collective. And we're also community builders. And so with this Project Echo, the foundation is we're in it to educate and build community. I think in order to address the opioid addiction issue that we have in this country and in this state, we have to be able to build communities across cultures, across gender. We have to build community to address it in a real way. And then we're committed to a common goal. And what that common goal may be, having dialogue, having conflict is how we come to a common goal. And then the last but not least, is be humble. Being humble can be challenging sometimes, especially, when folks lean on certain folks, us as professionals to be experts in the community. One of the things that I talk about in my family therapy piece is when I do family therapy, or individual therapy, I talk about people are experts on their lives. And we have to honor that, validate that, and make sure that people understand that, expert is not necessarily how you deal with challenges. Experts can look different in any different, given situation. So I want to talk a little bit about Empower Therapeutic Support Services. Has been in existence since 2007. I'm the co-founder of Empower Therapeutic Support Services. We initially began Empower around the mission. Our mission was to empower people, empower individuals and families to successfully transition through various phases of life while maintaining the ability to function effectively as independently as possible. We also strive to create a supportive environment in which to teach skills to navigate through life transitions while empowering individuals to be proactive in their lives. So our whole mission is built on empowering people. And I think that's a great thing, even though that was back in 2007 when we started, it's awesome that, even back then we valued, the person, the client perspective in their treatment, in their power, in their treatment. And I always talk about, because I'm an MFT, we talk about these common factors. So some of the common factors would be folks, what works in therapy. So 85% of what works in therapy has to do with the relationship between the clinician and the person who's receiving the services, and also that person's willingness to engage through that relational change, through that therapeutic process. And then the other part is just, treatment. I know it doesn't work that way in every area of healthcare, but I think it's relevant when we're talking about addressing opioid use to empower people, educate people, empower people, and support people with taking control of their lives. So our goals of services is to increase awareness. I got to shrink this because I can't see. To increase personal awareness and understanding regarding the family system. So if you're an MFT or any kind of therapist, you understand family systems. That's what we do. We do the family systems talk. So we treat the whole family rather than the individuals. And I think when we're talking about opioid use impacts community and the families. And so to openly just treat one person in the family and not support the family, that's it can be counterproductive, and it can reduce our outcomes. And the other piece is having relationships, understanding how increasing like the relationships, and then understanding what hardship are. And it's an accountability and a responsibility piece that we have. So if we're empowering people, it doesn't necessarily mean like we're going to be doing the cheerleader. We also can engage in positive conflict too, and hold people accountable and responsible for their own lives. And then also being proactive, helping them to be proactive in their decision making. And then increasing overall awareness of needs and strengths. So we just don't primarily focus on what do you need, what do you need, what do you need. We can focus on what are your strengths also? And I think that's the important part, especially when someone is struggling to figure out how to overcome this epidemic, the opioid epidemic, and how they have used it so long to, if we call it, cover up some problems that they have or issues that they have in their lives. So real quick, I don't like to bog people down with statistics, but it is what it is. We're going to keep it real. So in Minnesota, the Native American folks are 7 times more likely to overdose from drugs than as their white counterparts. And the African Americans are twice as likely to overdose and die from a drug overdose as their white counterpart. And then in 2020, ages 15 to 34 had the most significant number of ER visits for opioid involvement, opioid involved overdose. And so my resources, Minnesota State Health site, if you want to go check out some of those statistics. It's fun. If you're into statistics, that's a fun place to hang out. So with that being said, I want to say I'm proud to introduce Miss Priscilla Brown. She has been a partner of Empowered Therapeutic Support Services, and she's continued to provide us with valuable resources. We are partners. We're always sharing ideas. We're getting together. If I need someone to support the work that I'm doing, she's there. She's always available. And when she needs an idea, because I'm a big picture guy, she always brings me in to support the work that she does in any capacity that I can support the work with Urban Ventures or anything that Ms. Priscilla has done. I'm always on board. And I think that's what, like when we talked earlier about systemic leadership, that's kind of the collaborative. This is what it looks like in action. We come together, we work together, and we support each other. So I'm going to close my mouth, and I am going to pass it to Miss Priscilla, and then she'll finish the rest of our opioid piece, and then we'll have questions afterwards.
Okay. Thank you, Cedric, and good afternoon to everyone that's here with us today. Thank you for having me. Cedric said it just right. We have partnered in this work for at least 7-8 years, coming together and using the experiences and wisdoms of each other. And today I like to share from a personal perspective as well as a professional perspective, because I bring to the table both of them. My story, and I guess I probably should start with giving you a little background. My master's degree is in marriage and family therapy, so I am informed by that systemic system that Cedric was speaking of earlier. I earned my degree from Bethel Theological Seminary in May of 2003. I am a program director for 2 programs at Urban Ventures. One, the Pathway program, which is for adults, Nehemiah program, which is for youth. Right now, ages 15 through 19, I'm redesigning where I'm going to be moving down, unfortunately, because our children are getting younger that we're dealing with. So I will be serving from early as age 10 now to 19. I have, in the last 6 years, designed the first gun diversion program in the United States, which is now held as the model for the United States. There is only to date 5 gun diversion programs at this point. I have a wealth of experience in the mental health and chemical health community, the Black community. I've been working in this community for nonprofits as well as in the Black church community as through pastoral care for 33 plus years. And so I bring a wealth of knowledge from both a secular as well as a spiritual background. As I said, my story, though, I would like to just share a little bit about my story. I came into this, I lost a son. At the time, he was 19 years old, to gun violence. And at that point, that was the the trajectory of my life spiraled downhill very quickly. The only way that I knew at that point to deal with the trauma that I had experienced of losing a child, and especially losing a child to such a violent death, was to turn to drugs. And that was the only way that at that point that I could face life, or the only way that I thought that I could face life at that time. That was my life for nearly 2 years. Through and at that time, I ended up in a raid and was charged with having drugs, selling drugs, which was at that point very true, and I was doing that to support my habit. Now, what I'm going to say is not to blame, because I certainly was in an activity that was against the law. My problem is that I know at that point I was a college-educated Black woman, had a job that I was on a fast track. I was at that point working for the insurance agency, was on a high-level management track in the insurance company. At that point, I know that if I were a white woman, what my consequence would have been treatment and probation. During that process, no one spoke to me about looking at going to treatment for what was clearly an addiction led by trauma. And I say that because that is something, the underpinning causes for our community. And I think it needs to be looked at and said, because this is what we deal with constantly in our community. You want to move on? Mm-hmm. My mission is to be a change agent through my vision and my work with with community organizations. I am passionate about bringing organizations together to work on that and to work on that and are important to our Black community. My vision involves working with individuals and families through my work as a pastor in our Black churches as well, and to provide support and connection for people who struggle with addiction. You can move to the next slide. As I said, I right now currently work for Urban Ventures, and this is a quick video that I'd like you to watch. Urban Ventures has several programs that we offer to our community, and yet to people of color, and yet we still have the issues of disparity in offering health and mental health services to our community, especially to people of color, the Black community. That is still an issue that we have. As I said, the two programs that I provide leadership to at Urban Ventures is the Nehemiah program, which serves children, young people, the ages of 12 to 19 years old. At this time, they are receiving programming for anger management and also for trauma. And we are working with these young people, helping them to identify what trauma is in their life and how to identify, how to cope with trauma so that they are able to function in some kind of normalcy as they continue on in their lives. Next slide. The Pathway program is the adult program. That program, people are coming into that program who have been charged with carrying a gun without a permit. These are first-time offenders. Now, they have not used the guns, but they are caught for some reason, maybe stopped at a stoplight or speeding or something of that nature, have a pistol on them and are found not to have a permit. They come into the program for 9 months. And once they've successfully fulfill the program and stay crime-free for 3 years, then their record is expunged. Doing this program, we deal with 3 major classes. One, we are working with them on behavioral change, working with them to change their thinking, to change behavior. Again, anger management, and then again, working with them on the trauma piece, and that is similar to what we do with the youth, being able to help them to identify what trauma is, how it impacts their world in a negative way, and replacing that with some coping skills so that they are able to make the changes that they need to make. Adding to this, hoping and actually leading them to continuing on this process with looking at going further and deeper into mental health resources. Next slide. The opioid use in the Black community. The way that it has impacted us, it impacts us in poverty, incarceration of family members. When a family member goes to prison, it is not just that individual that is incarcerated. The incarceration incarcerates the whole family. It leads to poor health outcomes and definitely poor educational outcomes. Next slide. Impact on individual programs. It definitely causes a lack of program participation. It is very difficult, and we see this both in the youth program as well as adult programs. It is definitely hard to sustain any level of consistent program attendance if you're dealing with individuals who are using opiates or any kind of substance for that matter. It increases in negative mental health outcomes, lack of community engagement. It is very difficult to get people to stay committed and committed and consistent, I should say, in any other community engagement, and definitely it increases homelessness. Next slide. The impact on community. The community decline and struggles to remain healthy to make the needs to meet the needs of the individuals and families. This may include a lack of jobs, food, and healthcare resources. The possible solutions: community building, treatment versus incarceration. We know that incarceration is not the answer, is not where there's going to be solution or help to change the behavior of that person. It brings back to mind, and I was actually told when I went before the judge to have my record expunged 14 years after I had been released from prison. The judge told me to my face, she said, "I never really believed in rehabilitation, but you showed me different." That was from the judge that sentenced me. Education, family-centered treatment. We must treat the whole family. Taking the individual that is using, plucking that individual out of the system, getting them sober, and then returning them back to the system is not productive. Addiction has always been a systems problem, and we must look at it and treat it as such. It is not an individual problem. It is a systems problem. Intentional programming. We must have programming that makes sense. We must have programming that is going to include all of what's important to the clients that we are helping. Not what we think that matters to the client, but it has to be intentional programming. And then develop collaborative partnerships to do that work. The next slide. As I have as my work has provided me with the opportunity to work with individuals and families over, like I said, the 33 years in the area of chemical addiction and mental health, both from a secular and a faith perspective, I have decided that I want to continue my work with strengthening families and providing services, first in preparing couples for marriage. I strongly believe our families are dysfunctional and our families are torn apart, and we need strong families. Part of my work, I really believe that starts with first good, strong education, good, strong support in helping those that want marriage, providing that. parenting education and counseling, providing, again, good, strong education around parenting and counseling with parents around those issues. I don't know if some of you may have heard about the gun buyback that myself and one of the my service providers hosted with me just 2 weeks ago. Along the way, we came about a group of parents who are actually frightened of their young people who are carrying those guns, have lost the ability to parent. We need good parenting, education, and counseling and support around the parents, and then couple enrichment. That's, as I said earlier, I am a change agent in this work, and there's a lot of work to be done yet. And my work that I would like to continue and will continue is work with healing the family, because until we can heal the family, we will not have strong community. We will not have strong cities, and we cannot have strong states and so on. I thank you for listening.
You're muted.
Thank you, Ms. Priscilla. I really appreciate your insight and your vulnerability of sharing your story. Now I want to open it up to, a Q&A. So you can ask any questions that you may have. And because we have a short period of time in this echo, we're going to have more. And so if we don't get to your question this time, we could definitely,
Yes.
keep a list of it and note it, and then make sure that we can able to get to some of the questions. So, and then also add it to the chat if you need to. That helps us a bit to get to these questions.
Kushik, do you want to go ahead?
Yeah, Dr. Brown and Dr. Weatherspoon, thank you for talking about all the family-centered programming that you do. My question is, I really love your focus on families and from families transitioning into broader macro system as communities. However, larger health systems still function at a very individual level.
Yes.
There's a big fundamental disconnect there. That's where programming such as this, that's culturally specific, are really healthy and really meaningful. So have you came across those disconnects when it comes to your clients transitioning from family-centered programming to larger health systems, which are on an individual basis? And how do you support them? And you as a change maker, how do you also advocate to push those individual programming to become more family-centered and culture responsive?
You're absolutely right. It is a very, still in this day, you would think that it would be common sense that that's what worked, but it isn't. And one of the things that I'm doing right now in the Nehemiah program, in fact, and I really hated to go this road, down this road, but I've made it mandatory that the parent or caregiver, whichever, whoever it is that is responsible for the youth, they have to be part of the program. Because I've been doing the adult program for 6 years, the youth program for 2. The first year I, kind of just left it open, hoping that would happen on its own, which, I've been doing this work to know that it probably wouldn't, but I thought I'd try it. Not one parent that whole year. The whole year came along with their child. So this year it's mandatory. And as much, the problem is also that you can't get the support of other systems, because I really want it mandatory. I've got it that it's mandatory that the youth has to do therapy. I want it mandatory that the family has to do therapy while the youth is in the program. Well, the county, because the county is the one that foots the bill. They said, well, we can't support that. We can't make the parent do that. Well, I beg to differ. And we can. We need to start, using the power that we have. So as much as I am able to push the envelope, I do. And I will.
Well, what we tried, I think larger systems have pieces. I mean, like the ED department does not look like the PEDS department. I mean, everybody has their own silo. The common thing that I've seen in larger systems is, people who are advocates and social workers. And the larger systems also have community-based clinics. And so, in my opinion is, like, if I was to want to send someone to a client-based provider, I would lean more into those community-based systems that's all embedded throughout the community. Because most of the time folks have relationships with the providers there. They know the provider, know the community. And so they have a different type of relationship. And I think, for larger systems, we have to use the resources that are in place to bridge that gap between community and then the hospital system at large. And that can be challenging sometimes because you have so many moving parts. So that's why these project echoes are so valuable, because it gets the community together and get people together to talk. And the larger systems understand things from a systematic standpoint, all these moving parts at one time. But we also have to have bridge builders. Part of our vision is to develop community-based advocates that work exclusively with mental health providers. And ideally what I would like to see is, we have the relationship within the context in our community, and that provider can reach out to the advocate after we get the releases signed off to help bridge that gap, because the information that we have does not necessarily show up in the appointment. And so we want to try to, integrate that piece in there. I don't know how it's going to get paid for, but I think it's great to kind of have a bridge builder in between the two systems that have relationships with both systems. We've done it with children's mental health and correction, and it seemed to be very effective, because folks can call the bridge builder and the person who's actually receiving the services or on probation to be able to kind of be like a navigator or mediator between the two parties.
Love your response, Cedric. I think the liaison piece is super crucial. And again, you also pointed out a really great gap in the system, which Priscilla also pointed out, is like the liaison and the funding for that position, which is kind of harmonizing two systems, like there's a gap, and how do we transition from family-centered to individual-centered and going back to the family and closing that loop. And it becomes tricky when funding is at an individual level, and it's hard to move that deal. Just sharing my frustration. Thank you.
I'm curious, Priscilla and Cedric, how do you define family? Because I think our system is very simplistic with that. and often just kind of define it as a nuclear family. You know, if you have a designated spouse and your children, and beyond that, that's not really family. And I know, like for me, like family is my cousins, or they were in my village back home in Vietnam. That's family.
Mhm.
So how do
Mhm.
you navigate that in the
I
system too?
I let my client defines family. You know, the client whoever the client defines as family, we get in the room, whomever they are the ones that that tell us who is family, and that's who we, you know, ultimately, you know, look at who family is for this particular client. And we don't define that for the client.
Well, I would say historically we go, it has been like, we've always been community and village people. I
Exactly.
mean, like, our before, and I say this going back, when we look at systems like foster care system, let's take that as an example. When, you know, in some communities, you have elders in the community that are foster parents, and their responsibility is for the health of that family and for the child. And so instead of our system, instead of sending someone, child protection coming in and working with the child, we have a concerned community about the child's welfare, and we're able to send them to auntie's house. So auntie might be the person who's the advocate in our community. And so with our systems at large, they're like, well, is this your auntie? You know, where's her document? Is this your mom's sister?
Yes.
No,
Yes.
there's like the community providers that we
Right.
embedded in our community.
Right.
Now it's changed, that dynamic has changed significantly. And I think if I had to, you know, like challenge providers these days, is to understanding how the African American community is really changing, given that, you know, this whole notion of individuality in our culture, and not promoting families and community is about how much you got, what can you get out of your situation. Don't talk to my kid this way. I'll hide in shame on the individual level. And I think that might be the biggest barrier to accessing people who are struggling with opioid use, because we don't know where they are, because they're hiding. They're not necessarily emotionally connected to the community or physically connected to these relationships that we had deeply embedded in our community and kept our community healthy for so long. And so I challenge providers to understand and get out, you know, if you have been if you're kind of in a suburb area and you haven't navigated communities, then just educate yourself on a deeper understanding of what family is in the context of anyone's culture. And also understand that it changes too. And so being able to like be immersed in understanding cultural nuances is, I think that's what the practice is about. So when folks show up and say, well, my auntie has shown up with me, and they're not a biological person, as long as they sign off on that little paper and say, oh, is that okay for them to sit in here? Yeah, they're welcome to the dance. And the educational piece is educating the community about how do you navigate these systems that prevent that relationship from happening and that advocacy to happen. So if it's a release of information, just how can we educate communities around how do we get a release of information so we can support that person who is struggling with any addiction?
And another piece to add to what Cedric has said, educating yourself as well on how important is their community of faith to this person, because in some cultures, in some communities, that is a strong part of their family, and can be you know, a critical piece to that treatment and that, that piece that needs to be addressed in in the treatment planning. So those are huge pieces that many times gets overlooked, and it's important to have that information and have that piece as well.
I've got a quick question, and thank you both for your expertise. Obviously, if change is going to happen in someone's life, there has to be an internal component. They have to be motivated to pursue that. So if you have a patient or a client who is assigned to come to you guys, or that's who you're working with, how do you draw that out of them? How do you let them know that you're on their team and you want to work together with them, but they need to be involved?
Can I take this, Ms. Priscilla?
Yeah.
So one of the things that what we try to practice and empower is we allow community to take ownership for the space. What we've found is and I'll give you an example. We had an incident where someone came and they were upset. And so they knocked over some stuff. They knocked some stuff down. Instead of saying, hey, get out of my hospital and calling the police and calling security, I said, well, how are you going to do your clinic like this? And they looked at me like, what? It's like, well, yeah, this is your clinic. Yes, we run this clinic, but this is for you. So you messed up, you messed up your space. What can I do to support you so we can take better care of your space? So that was, in that particular incident, that was very empowering. Although that person might have missed 1 or 2, 3, 4 appointments, we understand, in mental health, in reality, we're just getting comfortable in the Black community. We're just getting comfortable with that notion of having a provider and how to navigate the mental health system. The same thing is with healthcare system. That's the reason why we have these disparities, because it's this assumption that when folks show up because we offer something, that doesn't mean they're going to be comfortable and trustworthy for us to be able to do the work. They have to build relationships first. And then that intrinsic motivation comes around trust. If you can look at even, the development of children, and I know this far away from the opioid use, but it's relevant because children just don't, they don't automatically say, I trust you. You have to do a battery of things to let them know I'm here to care for you. I'm here to support you. And it's okay for you to trust me. Mm-hmm. Because if you had an infant baby, they scream very loud. And if you never showed up for many years and then all of a sudden say, I got something for you, you're not going to be able to build trust. So I challenge people to look at the development of these relationships over time. Yes. And who can you invite in this community? This is why community building is so important in this fight, is because the more people you have to wrap around, the bigger network of trust. Because out of that network, they're gonna trust someone. I don't trust you, but if this person says you're okay, then I might trust you. Now, but it's on you to be able to hold that trust. Right. And I always say, I tell folks all the time, if I refer someone to you, that's the highest honor you can ever have. And I hold it to a higher standard, because if I lose my credibility, then we're deep in the fight now. You have to show up. And so that leader, I want to go back to that systemic leadership model that we try to talk about and that I'm trying to get folks to adopt. It's everybody's responsibility, not just one provider. Everybody's involved in that system, parent, the individual. All these folks are moving parts that really need to commit to addressing this opioid use issue.
Yes. Well said, yes.
I have a follow-up question. relationship building or this work is really relational, as you pointed out again and again. The big disconnect, again, the point is like, there is not adequate recognition or funding for the relational component of this work to happen.
Mhm.
And it's frustrating because without that, the default response is like, what am I doing wrong? Or why are people not trusting me, without, like looking into like broader systemic structures. So Cedric, like, in terms of like your journey of like, really raising awareness about systemic leadership, like how has been the broader response when it comes to connecting two different value systems?
Well, I think I always lean into this frame of thinking. We're in the perfect time for change. And so, all ideas, new ideas that we're doing, is a lot of changes that's happening. So my strategy is reaching out to people in this situation where people are panicking and saying like, hey, let's look for opportunity in this crisis. So introducing a systemic leadership way of addressing any kind of issue is the best way. I think it's the most productive way of addressing all the problems in healthcare, because we're seeing it, like it's not enough therapists to serve everyone. From a systemic leadership standpoint, you would have to engage healers. All these healers that have been pushed out of the center, we have to engage them now, because we don't have the capacity to serve all the mental health needs of everyone who's asking. Even in healthcare, you could see, if you're a doctor, you understand, you work on teams. It's not about the individual doctor anymore.
Right.
And I work with medical programs too. One of the things that they are introducing to folks is how to work on teams, how to work on a team, how to include the nurse expertise, and you're bringing people in. So the work is actually happening, but I think we need to kind of encapsulate it. And this is the type of leadership that is needed to address these complex problems that we are having in the world today, in this country, in this state, and in the world today. And I would also say one of the biggest systemic leaders is Bishop Desmond Tutu and Nelson Mandela. How complex were those problems that they were dealing with? And look at the body of work that they've done over time. It could happen. I mean, we're forced to change. And it's okay. I mean, I tell folks all the time, it's okay. That old stuff it was good when it lasted, but now we're in a new dawn of a new age. We have to be able to make the shift. And it's not pretty. It involves systemic leadership. Is not about the beautiful things I've just described. It's also about conflict. We have to have conflict, because with this change, conflict, it is change. You can, and if you think about a forest fire. Forest fire just levels forests, like forests, burns all the trees down, kills animals, does all of this stuff, and it's a tragedy. But after that forest fire is done, when that forest starts to recover and those flowers start to come back, it's a beautiful thing. And so when we're thinking about systemic leadership in the context of conflict, think about it in the way that, hey, sometimes we have to have those breakdowns and those conflicts to be able to get to the real beauty for that next generation to come through and flourish.
And I think one of the things you said, that we have to move into a place of humility. We can't be power seeking. We can't personalize. That I think is what I hear you saying as well. It's not about me. It's not about my failure. It's about looking at what do we've burned through all of what we know and what we do. How do we now take what we can learn and change and grow from that. And not personalize and make it about I'm a failure, because no, we all need to come together as, systemic leaders and put all of our wealth of knowledge that and Cedric said it earlier about our relationship. We come together and run, things, off of each other and are able to do that. It's not, like, okay, I know this, or I better know that. It's none of that. It's not about how much you know or how little I know. It's about what we know together and what we can learn to know and grow together for the greater good of everyone.
Well, it's 1:15. I don't want to hold people up too much. I really appreciate everybody who showed up, and I'm looking forward to our next Project Echo. Who, you got anything you want to say behind the mask?
I'm just thankful for you all. And thank you for giving this perspective and teaching me and learning a lot more about the community. Thank you.
Thank you. Learned a lot. I needed to hear that perspective. Thank you both.
And I, again, appreciate being invited, and thank you all.